Hello and welcome to Noon Conference hosted by Medality. Noon Conference connects the global radiology community through free, live educational webinars that are accessible for all and is an opportunity to learn alongside top radiologists from around the world. You can access a recording of today's conference and previous Noon conferences by creating a free account. Today, we are honored to welcome Dr. Suresh Mukherji for a lecture entitled Anatomy and Pathology of the Oropharynx. Dr. Mukherji received his undergraduate degree from Duke University and his MD degree from Georgetown University. He currently holds appointments at multiple institutions and is a devoted educator who has been an invited speaker on over 500 occasions and written and edited 15 textbooks. We're especially grateful for his support of Medality and for serving as our head and neck neuroradiology advisor. At the end of this lecture, please join him in a Q&A session where he will address questions you may have on today's topic. Please remember to use the Q&A feature to submit your questions so we can get to as many as we can before our time is up. With that, we are ready to begin today's lecture. Dr. Mukherji, please take it from here.
Okay, great. All right. Well, thanks again for having me at Medality. And this is actually the second part of a two-part session. We had the first one on the oral cavity, and now we're going to talk about the anatomy and the pathology of the oropharynx. So we're going to spend the whole 50 minutes or so talking about the oropharynx. And it's really up to the Medality folks. I blocked off time after this talk too, so we have plenty of times for question and answer as well. So that gives me the opportunity to catch up for a second, and that is, my son's in medical school right now, so I can attest to the fact that when you're actually in medical school, we don't really get a good foundation of the anatomy of the head and neck. And so all of a sudden, we're asked to evaluate anatomy and pathology of the head and neck. And now we're really specifically just talking about the oropharynx. So that's why, excuse me, I appreciate the opportunity to give talks about the anatomy and the pathology of this specific area, which is an incredibly important area. So we're going to talk about the anatomy and the pathology of the oropharynx. And the first thing to remember is that the oropharynx is part, if you will, of your mouth. But the oropharynx has four separate subsites, and those include this area here, which is the tongue base. You have the soft palate, you have the tonsil, and you have the posterior pharyngeal wall. So when you're looking at the sagittal images right here, it basically starts from the level of the circumvallate papilla and this area right here, which is called the anterior tonsor pillar. And don't worry about all of this anatomy because we'll go at it in detail. The posterior wall is formed by this muscular wall posteriorly, which is a posterior pharyngeal wall. Superiorly, it's supported by or bounded by the soft palate, inferiorly by the vallecula, and then laterally, again, by the tonsils. And again, we'll talk all about the tonsils again in great detail. But what I wanted to say was basically the oropharynx is kind of this rectangle in the back of your mouth, if you will, whereas this area, and you can see my this area anterior is the oral cavity. The oropharynx, if you will, is that area posterior to the oral tongue. I did want to talk a little bit about the embryology and not go too much into detail. But what I did want to say is that I don't really remember much about embryology. But what I did want to really specifically focus on is that when you look at the oral tongue here, which is on this top right image, the circumvallate papilla is bounded here in yellow. So this is the boundary of the circumvallate papilla. The oral tongue is predominantly formed by the first and second derivatives of the branchial arches, and it's innervated by cranial nerves 5 and 7. But when we look at the circumvallate papilla and going posteriorly, and we talk about the tongue base and we talk about the epiglottis, this arises from the third and fourth branchial pouches, and that's supplied by cranial nerves 9 and cranial nerves 10. And so if you look at this schematic illustration, the motor division, so if you actually have a hypoglossal nerve palsy, that innervates half of the tongue. So this is motor. But sometimes what we forget about is taste and sensation. So when we talk about the oropharynx, this is predominantly formed by cranial nerves 9 and cranial nerves 10. Now, I specifically mention this because if you did have a patient with otalgia, and otalgia meaning referred ear pain, there are many causes to that, but just remember cranial nerves 9 and cranial nerves 10 extend all the way to your middle ear cavity, through the nerves of Jacobson and Arnold's. So if you do have a patient with unexplained ear pain, please, please, please always to remember to look at the tongue base and the pharynx, because sometimes you'll pick up squamous cell carcinomas or other tumors that involve this area that can cause the ear pain. And we'll again go over that in great detail. So the first thing that we'll talk about in the oropharynx is we'll talk about this area right here, which is the tongue base. So as you know, there are two parts to the tongue. There's this oral tongue right here, which you kind of stick out of. When I was a kid, I used to get mad at someone. I used to stick out my tongue. And then there is this junction right here, which is the embryologic location that separates the oral tongue from the tongue base. So now we're going to be specifically looking at this area posteriorly to the circumvallate papilla. At the apex of the circumvallate papilla is a little foramen, and that's the foramen cecum. So this is what you look when you look at the surface anatomy of the tongue. Now, when you look at the anatomy, what you see here is that the tongue base is formed by these transverse fibers. So if you look anteriorly, these vertically oriented muscles are in the floor mouth, which is part of the oral cavity. But one of the questions I often get is, how do you know where the oral cavity ends and the tongue base begins? And that's because we see this termination of these vertically oriented muscles, and now we see these transverse fibers, which are the fibers of the tongue base. This is a CT scan, again, demonstrating the vertically oriented genioglossus muscles. And here we see the transition of the tongue-based musculature. So part of it is these transverse fibers that go right to left. But realize when you look at the CT, the tongue base has an intrinsically high area of fat as well, too. So it's not only the termination of fibers and these muscles, but you can see there's more low attenuation in here, and you can see the contrast between these thick muscles and the fat in the tongue base. So this talk is not going to be purely based on cancer. So we have special talks on squamous cell carcinomas involving the oral cavity and the oropharynx that get into a lot of detail. But this talk is really going to be on differential diagnosis. So we'll touch a little bit about the most common tumor to involve the tongue base, and this is squamous cell carcinoma. So here's an example of a tumor involving the right tongue base demonstrating the various patterns of spread. And this is an example of squamous cell carcinoma involving the tongue base. So here we can see this mass is centered on the tongue base. If we look anteriorly, we can see that this tumor is extending anteriorly and traversing this junction between the genioglossus muscle and the tongue base. So this is the classic example of a tongue-based carcinoma. Now, when we talk about tongue-based carcinomas, I'm sure all of you are familiar with the squamous cell carcinomas of the tongue base, which are HPV positive. So I should say in the United States, the vast majority of squamous cell carcinomas involving the oropharynx, and that's the tongue base and the tonsil and the soft palate, are HPV positive. So I'm sure all of you are familiar with this, but just realize these primarily involve the oropharynx, whereas HPV negative tumors involve the oral cavity. I think you're also aware that this HPV positive tumor can be considered a sexually transmitted disease because HPV is oftentimes transmitted during birth in the vaginal canal. The one good thing about HPV positive tumors is that these tumors actually have a better overall survival rate compared to HPV negative tumors. Now, one little nuance that I wanted to mention, because this can be a little bit confusing, is that when we talk about HPV, this is human papillomavirus, and it is the most commonly sexually transmitted disease. It is a true oncovirus, and the subtypes are HPV 16 and HPV 18. Now, I mention this in particular because sometimes it can get confusing, because we also talk about this concept of P16 positive. So the point that I want to make is, and one of the unfortunate coincidences is that the most common type of HPV that involves the head and neck and results in these cancers is actually the HPV 16 virus. So this comprises about 90% of all HPV tumors. So if you do PCR testing, polymerase chain reaction testing, then you are going to test for this HPV 16. But on the other hand, you've probably heard about P16 staining. And what this is a immunohistochemical stain. And just by coincidence, this P16 protein is expressed by various viruses. And so if you have a patient that has a squamous cell carcinoma, sometimes the ENT surgeons or the pathologist will not perform the PCR testing, but they'll just do an immunohistochemical stain and they will test for the P16 protein. So I did want to point out the difference between the PCR testing, which is we're all familiar with as we come off of COVID, versus the immunohistochemical staining. So when they do stain for the the P16 protein, you can see it's darker here compared to a normal stain here. So it's one of those unfortunate coincidences. So by far and away, the most common tumor that you'll end up seeing in the oropharynx is going to be squamous cell carcinoma. Now, the second most common tumor that you will see is a result of this lymphoid tissue that's in your oropharynx and also part of your nasopharynx. And this is what was referred to as Wall-Dyer's ring. So Wall-Dyer's ring has lymphoid tissue here involving the tongue base and specifically located here in the vallecula. And we refer to this area as the lingual tonsils. So now that we're specifically talking about the tongue base, we know that there's lymphoid tissue here. And this was a patient that has lymphoma that's kind of tucked away right behind the tongue base, but anterior to the epiglottis in the region of the lingual tonsil. Now, these lingual tonsils can actually get pretty big and they actually can be pretty confusing. So this is an example of a patient that presents with a tongue-based mass that's involving the lingual tonsils. And you look at this and you're like, holy cow, is this squamous cell carcinoma? What do you do? Here's another patient that has another big mass right here that's located right in the region of the vallecula. Now, for all intents or purposes, this looks like either squamous cell carcinoma or it could be lymphoma. And lymphoma, again, because of that predominance of lingual tissue. But in actuality, this was path proven to be lingual tonsillitis. So you actually can get inflammation of these lingual tonsils and give you a very, very large mass in this area. And the only way that we can differentiate this is really by physical examination, palpation. So these are two patients, and one of these has lingual tonsillitis, and I have the answers here below. But you can see this was a patient that actually has squamous cell carcinoma, and this is what it looks like on CT scan. And this patient ends up having lingual tonsillitis, and this is what it looks like on clinical exam. So the challenge that I run into every day is that if I have a patient with throat pain or difficulty swallowing, or sometimes with ear pain too, right? Because remember that referred pain that goes to your ear because of cranial nerves 9 and 10? Part of the challenge that I run into is if I see something like this, what do I include in my report? So what I end up saying is that if I see this increased soft tissue that's located in the region of the lingual tonsils, I just say there is increased soft tissue involving the region of the tongue base and extending into the vallecula, and this can be directly evaluated with physical examination and palpation. Now, I think those of you that have seen me lecture before know that I typically see patients on Wednesdays. And so when I do see those patients on Wednesdays, I know how easy it is to look back at the base of the tongue and palpate the base of the tongue. And if they palpated this lesion here on the middle, this would be a rock hard mass and they could see the squamous cell carcinoma. But in this situation, it would be soft and pliable, easily compressible, and this is lingual tonsillitis. So most occasions, this can easily be seen on physical exam, but for us, it's hard to say. So that's why I always specifically include that in my report if I do have any ambiguity. So the most common tumor of the tongue base is going to be squamous cell carcinoma, followed by lymphoma. The next thing that we have to remember is that we can have these ectopic rests of minor salivary gland tissues. Now, salivary gland tissues is typically seen in the major salivary gland. So it's typically seen in the parotid gland, it can be seen in the submandibular gland, and so on and so forth. But when we actually look in the head and neck, you can have these small little areas of salivary gland tissues that get lost, and they wind up in very strange areas. And some of those areas where they can arise includes the oral tongue. Here we have an illustration of the circumvallate papilla, and they can also arise in the tongue base. So as a result, we can actually have various types of minor salivary gland tumors that arise in the tongue base. So this is an example of adenoid cystic carcinoma, and this is an example of a polymorphous adenocarcinoma that we just recently saw. So the thing is, from our standpoint, there's really no way that we can differentiate squamous cell carcinoma from lymphoma, from these minor salivary gland tumors. So our job is just to confirm that there is a mass there that our physicians may see or palpate, and really to determine the full extent of the disease. But again, from our standpoint, there's no way to be specific, but on the other hand, we can include this in our differential diagnosis. So those are the three main tumors that involve the tongue base. Now let's talk about some congenital lesions that can involve the tongue base. And in order to do this, we'll talk about the thyroid gland. So the thyroid gland starts right here at the tongue base at the level of the foramen cecum. It then has this relative descent in the neck, and it has this complex relationship with this bone right here, which is the hyoid bone. So here we can see the descending thyroid gland on top. It courses anteriorly, then it can actually go behind the hyoid bone, and eventually it ends up in its resting space down here, which is in the anterior portion of the neck. So in the context of this talk, we're going to limit our discussion to those thyroid remnants that are stuck, if you will, involving the tongue base. So if we see a cystic mass right here that's located in the tongue base, then this is what we refer to as a thyroglossal duct cyst. And as a result, the type of surgery that's performed by our surgeons is called the cyst trunk procedure, where they take a cuff of the tongue base and they always want to extend all the way down to the anterior neck. And this surgery is still the classic procedure when they try to remove thyroid remnants such as thyroglossal duct cyst. Now, this, on the other hand, is not a fluid-containing structure, but these are actually examples of lingual thyroid. So in this particular case, we can see this focal area of increased attenuation, this increased attenuation mass located at the tongue base. This is actually lingual thyroid. And on this non-contrast study, what we see here is the high attenuation that's due to iodine being concentrated in that lingual thyroid gland. Now, when you do give contrast, this lingual thyroid is hypervascular, and that's what we typically see in the thyroid gland. We know the thyroid gland typically enhances with contrast. So here we have robust enhancement here located right at the expected location of the foramen cecum. And then when we look down in the anterior neck, we can see that there's no masses at all and no normal thyroid gland where it should be located. So this is just confirmatory that this large mass right here is in the lingual thyroid. So that's the oropharynx, and we specifically talked about the tongue base. So it's everything anterior here to the everything that's posterior to the circumvallate papilla. Now what we're going to do is that we're going to begin our discussion of the tonsil. So when we talk about the tonsil, there are specifically three components of the tonsil. So when we look at the tonsil, the main part of the tonsil right here, where this lymphoid tissue is located, has a couple of names to it. It can be either called the palatine or the fascial tonsils. And for those of you that have ever had a tonsillectomy, it's this part of the tonsil that's been removed. So in general, we tend to lump all the tonsil together, but because we're specifically talking about the oropharynx, and if we really want to convey to the surgeon that we're talking and using the same language, just realize that there's a component of the tonsil here, which is called the anterior tonsillar pillar, and there's a component posteriorly, which is called the posterior tonsillar pillar. When we look deep to the tonsil, it is located in this capsule, and just deep to this capsule is this superior constrictor muscle. So this superior constrictor muscle forms the lateral pharyngeal wall. Now, when you look posteriorly, we'll come back to this a little bit later. This is the posterior pharyngeal wall, but now we're just going to concentrate on this area here. Now, some of the applied anatomy that you have to be familiar with is that this anterior tonsillar pillar is in close proximity to this superior constrictor muscle. This constrictor muscle can extend anteriorly and interdigitates with the buccinator muscle to form this little area right here, which is the pterygomandibular raphe, and just medial to this is the retromolar trigone. So these areas right here are actually in the oral cavity, whereas this anterior tonsillar pillar is in the oropharynx, and this is formed by the muscle that goes from the palate to the tongue base, which is the palatoglossus muscle. Now, you always ask that question, well, so what? Why is Suresh going on all of this stuff, this big tangent? And the reason is that you can have different cancers involve different anatomical components. So this is an example of a tumor that's involving the anterior tonsillar pillar. So why does that make a difference? It makes a difference because this anterior tonsillar pillar extends inferiorly along the palatoglossus muscle to involve the tongue. But notice the location, it's pretty anterior. Now, this tumor can extend deeply. It can jump on the superior constrictor muscle and then grow right here to the pterygomandibular raphe. The reason why that's important, because if the surgeons tried to just resect this tumor here, let's say they wanted to do a transoral robotic surgery, this tumor is growing along this muscle to the raphe, and it's very possible they would have a positive margin. I know with me in our tumor board, if I have a tumor in the anterior tonsillar pillar, and I tell our surgeon it's growing anterolaterally along this buccinator muscle, they're not going to treat this with transoral robotic surgery. Similarly, oftentimes in these specific areas, it's really important to test for HPV because a certain percentage of these are not going to be HPV positive. They would actually be HPV negative because this little muscle right here is a transition zone between the oral cavity and the oropharynx. So this is a really tricky area, but I specifically wanted to mention this because we are talking and having a dedicated talk on the oropharynx. So when you actually look in someone's mouth, you can see this. I don't know if you're by yourself or maybe you're sitting with a friend, but if you want to get to know them, have them open their mouth. So when you open your mouth, this little anterior fold of tissue corresponds with the anterior tonsillar pillar. Now, as you're opening your mouth, you can look at another tonsillar pillar, which is posterior. And this is what we refer to as the posterior tonsillar pillar. This posterior tonsillar pillar is comprised by a muscle that goes from the palate to the pharynx, hence the name palatopharyngeus muscle. Now, these tumors are pretty rare. I've only seen a handful that were actually felt to be arising from the actual palatopharyngeus muscle or the posterior tonsillar pillar, but this just happens to be one of them. And notice how this tumor is located much more posteriorly than the anterior tonsillar pillar. So again, this is more of a much rarer tumor. And to be honest with you, I don't spend too much time on this because the bulk of the tumors that we'll end up seeing are arising from this part of the tonsil, which is referred to as the fascial or the palatine tonsil. So when we look at this specific piece of anatomy, this is comprised of the lymphoid tissue that Waldeyer described in Waldeyer's ring. So when we look at this tissue, it's located in the tonsillar fossa, and this is where approximately 90% of squamous cell carcinomas arise from. So this is an example of a schematic illustration of squamous cell carcinoma involving the tonsil. So this is the schematic illustration. Here's what you normally see. And this is an example of squamous cell carcinoma involving the left fascial tonsil. Now, if you're reading out a study, oftentimes you're going to say, well, it's a squamous cell carcinoma, and you've made the diagnosis and you're done with it. But because, we're specifically spending this time on the oropharynx, what I want to do is really focus on the information that's really going to make a difference in these patients. Because quite frankly, oftentimes the surgeons and the radiation oncologists already know the patient has a squamous cell carcinoma in the tonsil. From their standpoint, the main decision they need to make, and you especially, God forbid this should happen to you, is this something that I can treat with surgery and do a tonsillectomy, maybe through a transoral robotic surgery, or is this something that should be treated with radiation and chemotherapy? And this is really where we add our specific value. So this is an example of an exophytic tonsillar carcinoma, and you can see that there's no deep extension. So if we see something like this, and this is the type of patient that can be treated with a standard tonsillectomy or potentially TORS. Now, this is another example of a patient that has a tonsillar carcinoma. So if you make the diagnosis of tonsillar carcinoma, and say it's squamous cell. Well, that's good. And congratulations, but let's talk a little bit more. What are the things that's going to make a difference from a treatment standpoint? So notice how this squamous cell carcinoma is extending inferiorly into this space that's next to the pharynx. And what do you call the space that's next to the pharynx? Well, that's the parapharyngeal space. So the normal parapharyngeal space is this triangular space that's just deep to the pharynx. Notice how on the left-hand side, this tumor is extending deeply and is obliterating the normal appearance of the left parapharyngeal space. So if I say this to our surgeons, then these patients are not going to be treated with surgery, but they're typically going to be treated with chemotherapy and radiation therapy because these tumors are predominantly HPV positive. Another example here, look at the little apex right here. Look at this sharp line right here that's between the fat and the lateral and the medial pterygoid muscle. Notice how that's obliterated. So if I tell the surgeons this again, they again are going to be a little bit hesitant because in order to get a margin, they may have to take a piece of this muscle, which can be very hard to do through transoral robotic surgery. And notice how this tumor is actually growing anteriorly. Notice my favorite stripes right here. I always talk about my tiger stripes. Everyone gives me a hard time about this, but you can see the gray, then you can see the black, and then you can see the gray. So you see some nice tiger stripes on the patient's right side, and notice how these tiger stripes on the patient's left side are obliterated. And this is all tumor that's extending anterior laterally along that superior constrictor muscle. So these are three specific areas of spread patterns. And when you look at this image on the left, you can, we've sort of indicated these. That's going to make a difference on whether these patients can be treated with surgery or maybe better treated with chemotherapy and radiation therapy. The other thing too is that when we're looking at this, this is a patient that's had a right-sided tonsillectomy, and this is a patient with squamous cell carcinoma on the left. And the reason I show this is that this is something, again, we encounter every day. So if you're looking at something like this, you're like, oh my gosh, does this patient have a left-sided squamous cell carcinoma involved with the tonsil? Draw a line down the middle, compare one side to the other side. So it is important to mention this asymmetry in the mass, but just realize the surgeons and the radiation oncologists can look directly in the mouth. And in this case, that they can see this tumor, this exophytic tumor that's staring them literally in the mouth, and a pun intended for that one. And this corresponds to this squamous cell carcinoma. So the point being, if I see something like this, I'll go ahead and mention the asymmetry. But knowing that you can look in someone's throat, the surgeons can look directly in, look at the tonsils and palpate them and determine which is the residual fascial tonsil in a patient that had a right-sided tonsillectomy. So this is just retained lymphoid tissue on the left versus squamous cell carcinoma on the left. So remember, the majority of what we can see in the visceral space can be seen through endoscopic evaluation. Now, we're going to return to my friend here, Waldeyer. And remember, Waldeyer's ring, we talked about the lingual tonsil here. But remember, there's lymphoid tissue here that's involved in the tonsils. So as a result, when we're putting together our differential diagnosis for tumors involved in the tonsils, the second most likely is going to be lymphoma. So this is an example of tonsillar lymphoma. And this was a patient that has massive lymphadenopathy due to lymphoma. So in this particular case, we're not going to be able to make a specific histologic diagnosis, but what we can comment on the asymmetry, and then when the surgeons look in, they can see this mass extending into the visceral space, they can see it's large, and then they can take a biopsy. So really our job is to confirm that there is a mass involving the left tonsil, and it's really going to be up to the surgeon to confirm it, and then also the pathologist to give you the specific diagnosis. Now, part of the challenge that you run into when you have various lesions involving the tonsils, and especially in infections, is they can be pretty confusing. So this was a patient that we ended up seeing in our clinic about a year ago. This patient was seen, had a bit of a sore throat, and on an outside CT scan, on a head CT actually, it was noticed that there was some fullness in the tonsil. So they came to our clinic, we did a regular neck CT, and lo and behold, we see this large mass involved in the tonsil. And you can see how it's obliterating the parapharyngeal space. So when we looked at it, the surgeons looked at it, and I actually saw this patient too. We couldn't see a mucosal lesion. And when they palpated, it was completely soft. There was no focal mass at all. So we kind of wondered about this because in general, patients with tonsillitis have a pretty hot tonsil. But we decided just to wait. And then lo and behold, about 2 months later, the patient came back for a repeat MR. We were sort of suspicious of tonsillitis. The patient was put on antibiotics. And lo and behold, we can see that that mass right now is completely resolved. And now we can see a normal parapharyngeal space on the right. So this was an example of a tonsillitis that was mimicking squamous cell carcinoma. Now, the most common scenarios that you'll see are patients that end up having these infections involving the tonsils. And if they become really severe, they can end up developing these peritonsillar abscesses. Now, I've seen both the term peritonsillar abscess and tonsillar abscess used. I try not to get into the debate. Either one of these are fine. But what's most important is that if you do see a fluid collection involving this peritonsillar region, it is important to properly place this in the correct location. So if we draw a line down the middle, compare the right side to the left side, this is the normal left tonsil and this is the parapharyngeal space. Now, this is normal in this patient. Now, on the right-hand side, what we see is diffuse enlargement of the tonsil with low attenuation involved in the tonsil. So this abscess right here is actually located in the tonsil. In this particular case, draw a line down the middle, compare the right side to the left side. Here's the normal tonsil here, and this is the parapharyngeal space. In this case, we can see that this fluid collection is located in the parapharyngeal space, and the tonsil is not involved. Why does that make a difference? Well, it makes a difference even though it's just a centimeter or so from here to here. If we say that this is located in the tonsil, then this can be drained through an intraoral approach. But on the other hand, if this is an abscess in the parapharyngeal space, then this requires a cervical approach. So we as a radiologist, when we're looking in this area, it's incredibly important if we see something like this to properly place it either in the tonsil or in the parapharyngeal space because it directly affects how these abscesses are drained. Now, those were acute infections. What ends up happening is that you can have tonsillitis that's chronic. And I can attest to this because when I was a kid, I would always have strep throat. It was terrible. My parents always wanted me to get my tonsils out, but I would run and scream and shout, and I was always able to get away with it. So I never had my tonsils taken out. But if you do have chronic infections involved in the tonsils, what can happen is, first of all, they can look kind of ugly. These actually, you can see a little bit of enhancement here. This is just a severe case of chronic infections involving the tonsils. And you can obviously see these calcifications here, which correspond to these calcifications that we refer to as tonsillets. So this is an example of chronic inflammation of the tonsils. In this case, it's bilateral tonsillets. And in this particular case, we can see the string of pearls, if you will, involving one tonsils. So not only can tonsillets be bilateral, but they can be multiple and they can be unilateral as well. And again, just a sequela of a chronic infection. Now, this can be a fooler. Here we're looking in the right tonsil in the lateral wall of the pharynx, and we see this diffuse thickening involving the right neck. And when we look in the parapharyngeal space, we can see this obliteration, and we can see all of this hematoma and subcutaneous thickening. And this was an example of trauma. So this patient had a severe trauma to the right neck, and as a result, developed this large hematoma involving the tonsil. Now, if you looked at this on your own, we really couldn't separate an infection from trauma, but certainly in situations like these, when you see something this extensive, you should always try to get the history. And this was just an example of diffuse edema and hematoma involving the right tonsil. Now, one of the things that I've learned over time, and you guys may have heard me say this, is that good judgment comes from experience and experience comes from bad judgment. So when we start looking at this specific disease here, or this specific entity, this is a type 2 branchial cleft cyst. So I always felt that second branchial cleft cysts were always like this. But in actuality, there are different types of branchial cleft cysts. So when I was a resident, I was always taught in my pediatric rotation that you can have fistulas that go from the tonsil laterally, and those were second branchial cleft cysts. But more commonly, I'm used to seeing second branchial cleft cysts like this. Well, in actuality, there are different types of second branchial cleft cysts. And different types of second branchial cleft cysts can have fistulas that extend from the tonsil and extend through the carotid space and extend laterally between the plane of the carotid and the jugular vein. So this is an example of a type 3 second branchial cleft cyst. So if you've ever seen that fistula that extends from the tonsil and extends out to the skin, this is an example of a type 3 second branchial cleft cyst. Now, if you have that branchial cleft cyst that is medial to the plane of the carotid and the jugular vein and adjacent to the airway, then this is actually a type 4 branchial cleft cyst. Now, oftentimes when we look at the tonsils, we'll say, well, this is probably a retention cyst or post-inflammatory or so on and so forth. But just remember, when we have these cysts that are located in the tonsil, a certain percentage of these are going to be a remnant of a specific type of second branchial cleft cyst, and that is a type 4 branchial cleft cyst. So this is some of the more unusual congenital or developmental lesions that can involve the tonsil. So the next area that we'll talk about is the soft palate. So when we look at the soft palate, we already talked about the anterior tonsillar pillar and the posterior tonsillar pillar and the tonsil. But when I think of the soft palate, what I always end up thinking about is this palatal arch. So when we talk about the palatal arch, we have these muscles extending superiorly, and then we have this arch of tissue, and this arch of tissue forms a soft palate. We're all familiar looking with the soft palate on the sagittal images. It's this floppy piece of mucosa and muscle right here that ends in our little area right here that's called the uvula. The primary muscles that tether the soft palate are two Italian muscles, and these are the tensor and the levator velli palatini muscles. So this is the tensor velli palatini muscle. Here we see the tensor here, and this is the levator velli palatini, which raises the soft palate. So when I think of the soft palate, I always think of the Roman arch. So the lateral walls right here are the tonsillar pillars that we talked about. Then you have this communication with the soft palate, and eventually the soft palate has to be tethered to the skull base. And this skull base, for me, this tethering is formed by these tensor and levator velli palatini muscles. So this is what we refer to as I think of the palatal arch and how it's tethered to the skull base through those muscles. So when we think of tumors involving the soft palate, again, like anything else, the most common tumor is going to be squamous cell carcinoma. So this is an example of a squamous cell carcinoma we just saw in clinic 2 weeks ago, and we can see that it's hanging from that soft palate. Now, a couple things about soft palate carcinomas that I want to emphasize. Because it's oropharynx, they're going to be HPV positive. The second thing about soft palate carcinomas is that if we go back to this slide right here, this soft palate goes from the right side to the left side. It's not like the tonsil is on one side or the floor mouth is on one side. Rather, this soft palate goes from one side to the opposite side. So when we do have these soft palate carcinomas, they tend to grow circumferentially. So this is an example of a soft palate carcinoma. Notice when your eye sees something, we tend to compare right to the left, but this is more circumferential. So sometimes soft palate carcinomas can be difficult to detect on axial images. So it's always important to look at the sagittal and the coronal images because that'll help us better define it. So number one, they should be HPV positive because they're oropharynx. Number two, sometimes they can be challenging to identify in axial images. And then number three, these soft palate cancers have a tendency to metastasize to the retropharyngeal lymph nodes. So this is an example of a metastatic retropharyngeal lymph node that was clinically occult that metastasized from a soft palate carcinoma. So when you're looking at the soft palate, or if for that matter, anywhere in the oropharynx, you always want to see whether or not these retropharyngeal lymph nodes are involved. The other thing about soft palate carcinomas is that they can actually extend superiorly into the nasopharynx. So we talked about this spread inferiorly, but realize these soft palate carcinomas can grow superiorly. So here's an example of a soft palate carcinoma, and what you don't know at times is how much is it extending superiorly. So when we look at this area here involved with the nasopharynx, this is our torus tubarius. This is our opening of the eustachian tube, and this is the fossa of Rosenmuller. Draw a line down the middle, compare the right side to the left side, and notice the left torus tubarius is diffusely thickened, and this is squamous cell carcinoma growing superiorly up into the nasopharynx. Another example here, here's the torus tubarius. This is all this tumor growing on the torus tubarius, and oftentimes this tumor is clinically occult. So if the surgeons ever contemplated about resecting a soft palate carcinoma, which occasionally does happen, if we tell them that this tumor is growing superiorly into the nasopharynx, and these patients are certainly going to be treated with chemotherapy and radiation therapy in the majority of institutions. Now, when we look at the soft palate, we also have a higher incidence of these minor salivary gland rests. So the next most likely tumor to involve the soft palate is not going to be lymphoma, but it's going to be minor salivary gland tumors. Remember, lymphomatous tissue is in the vallecula and the tongue base and the tonsils, but there's very little lymphoid tissue involved in the soft palate. So the second most likely tumor is going to be a minor salivary gland tumor. Now, this is an example of pleomorphic adenoma involving the soft palate, and this is an example of adenoid cystic carcinoma involving the soft palate. Again, there's really no way for us to differentiate this. If you did see a tumor involving the soft palate and it was high signal on T2, as we could see in the parotid gland, well, we could suggest the diagnosis. But in general, when these patients present, it's really, really hard to differentiate. So we just have to include this in our differential diagnosis. There are some lesions that are specifically unique in children that we may see involving the soft palate. This is an example of a fatty lesion that's involving the soft palate. This happened to be a dermoid involving the uvula. This was a patient that had a vascular malformation. In this case, it was a low flow vascular malformation and represented a lymphatic malformation. And this, unfortunately, was the most common soft tissue malignancy to involve the soft palate, and this was rhabdomyosarcoma. So there are some unique things that oftentimes present in children involving the soft palate that we have to aware about. We can make this diagnosis because we can see the fatty component. If we see something in the soft palate that's high T2 signal and involves multiple spaces, and it's soft and pliable, we can suggest the vascular malformation. And unfortunately, in something like this, I think if you see this in a child and it's solid, then you really have to raise the possibility of rhabdomyosarcoma. And then the last area that we'll end up talking about involving the oropharynx is the posterior pharyngeal wall. Now, this posterior pharyngeal wall is an important area, but it oftentimes doesn't get the love that it requires. We spend a lot of our time talking about the tongue base, the tonsil, and the soft palate, but this posterior pharyngeal wall is a pretty important area that we will pay a little bit of attention to now. So when you look at the posterior pharyngeal wall, it extends all the way up to the skull base, all the way down here to the base of the cricoid cartilage. Now, this area that we are talking about today is the oropharynx, and it's predominantly comprised of this constrictor muscle, which is the superior constrictor muscle. So the anatomy of the posterior pharyngeal wall is mucosa, it's muscles, and predominantly it's the superior constrictor muscle with the part of the middle constrictor muscle forming the most inferior portion, and the innervation is from the pharyngeal plexus. And remember the embryology of the pharynx. Remember cranial nerves 9 and 10. Hopefully that's a little takeaway for you because the pharynx is formed by the third and the fourth branchial arch. And 9 is the nerve for the third and 10th is the nerve of the fourth. So we can always remember that the innervation for the pharynx is going to be the 9th and the 10th cranial nerve and the pharyngeal plexus. So just to review what we talked about, this was a circumvallate papilla, this was foramen cecum, this was the tongue base. When we went laterally, this part was the tonsil, anterior tonsillar pillar, posterior tonsillar pillar, fascial tonsil, and deep to this was the superior constrictor muscle. Now, if we follow the superior constrictor muscle posteriorly, notice how it makes this 90-degree turn, and this same muscle forms the posterior pharyngeal wall. So it's all continuous, but it's this segment from here to here that we consider the posterior pharyngeal wall. So the most common tumor that we end up seeing in the posterior pharyngeal wall, again, is going to be squamous cell carcinoma. And the majority of these are going to be HPV positive. Now, these tumors that are limited to the posterior pharyngeal wall are overall pretty rare. And quite frankly, these can be seen pretty easily. So the surgeon can look in and they can see this large tumor involving the posterior pharyngeal wall. So from our standpoint, what is some information that we need to provide? First of all, if we see this tumor involving the posterior pharyngeal wall, we want to see whether or not the retropharyngeal lymph nodes are involved. So if these retropharyngeal lymph nodes are involved, then the surgeons, if they wish to resect this squamous cell carcinoma, are going to have to take out these lymph nodes. Secondly, one of the true contraindications for resection of posterior pharyngeal wall squamous cell carcinomas is if these tumors invade the paraspinal muscles, and these are the longus colli muscles. And we can do this with a relative degree of confidence on MR. So this is an example of a posterior pharyngeal wall carcinoma, and we can see normal appearance of the longus colli muscles. But in this case, another posterior pharyngeal wall carcinoma, and when we look at the T2 weighted images, we can see edema here involving the longus colli muscles. So if we see edema involving the longus colli muscles, this is usually indicative of direct invasion. And if we see this, then that is a reason that the surgeons will not operate on these patients. So if you see that, as I mentioned before, it's a direct contraindication. In the old days, the surgeons would go in and try to wiggle the posterior pharyngeal wall. This was before the days of MR, but I got to tell you, most surgeons I talk to now are asking us to perform MR to see if we see any edema. So, things certainly have changed over the last few years. Now, what are some other tumors that can involve the posterior pharyngeal wall? Again, number one is going to be squamous cell carcinoma. Now, these are some example of some other tumors that can involve the posterior pharyngeal wall. Again, they're non-specific. If you are from Africa or if you have a patient that's HIV positive, occasionally you can see this. This is an example of Kaposi sarcoma. If you saw this in a child, well, again, the most common head and neck malignancy in the child is going to be a soft tissue malignancy, is going to be rhabdomyosarcoma. And again, this is an example, if you're from an endemic area, this is an example of Burkitt's lymphoma involving the posterior pharyngeal wall. So again, they're non-specific appearance. In the US, we don't see Kaposi's or Burkitt's that much, but because we do have a global audience, if you are in an endemic area for Kaposi's or Burkitt's, especially from Africa, this is something that you may end up seeing in your practice. You can have a variety of congenital or developmental lesions that affect the posterior pharyngeal wall. Now, this is something that I commonly see, and this was a case that I just had on Monday. This patient presented with dysphagia. So we always want to exclude a squamous cell carcinoma, but remember, as you get older, you can develop these big osteophytes. So this is an example of a large osteophyte that's resulting in mass effect involving the posterior pharyngeal wall that's resulting in the dysphagia. So it's not necessarily arising in the posterior pharyngeal wall, but it's certainly displacing it. Here's an example of a patient, again, that can present with dysphagia, or sometimes the surgeons will look down and they'll see a submucosal mass and they're not sure whether it's pulsatile. So what we always want to do to see is whether or not this carotid artery can sometimes be ectatic and extend into the retropharyngeal space. And this is the reason this patient has this submucosal mass involving the posterior pharyngeal wall. Certainly you don't want to biopsy that because that would be a disaster, but that's something we always want to include in our reports. And this was an example of a patient that has a large fluid collection, and this was a large calcification, which was a phlebolith. So occasionally you can have vascular malformations. In this case, a low flow vascular malformation extend into that retropharyngeal space. Now, one of the most common things that you'll end up doing is that if you do have a posterior pharyngeal wall tumor, as is seen here, as I mentioned before, these patients are oftentimes treated with chemotherapy and radiation therapy. So this is pre-treatment. Then after treatment, what we have is the expected post-treatment changes of the posterior pharyngeal wall. So what we have here is diffuse soft tissue thickening involving the posterior pharyngeal wall. And if you look deep to this, this is just edema. So this is not recurrent tumor because these findings are symmetric. Rather, this is just thickening and radiation changes following high-dose radiation and chemotherapy with underlying edema involving the retropharyngeal space. Now, you can have certain infections that can involve the posterior pharyngeal wall. This is an example of fungus. Now, for all the world to me, this looks like squamous cell carcinoma. So if I looked at this and I said, wow, this looks really bad like squamous cell, it very well could be. But it's really up to the surgeons to look down and look at this and also correlate it with any clinical findings. It's possible the patient can have a really, really sore throat. They may be immunocompromised or other predisposing factors. And this was an example of a diffuse fungal pharyngitis. This was most likely Candida. So in untreated Candida, we could see something like this. And if in fact these infections are not properly treated, these infections involving the posterior pharyngeal wall in a different case can actually pierce through and form a fistula into the retropharyngeal space. So this was a patient that had an untreated infection involving the posterior pharyngeal wall. This patient developed a fistula and unfortunately developed an abscess involving the retropharyngeal space. And we can see how it's displacing the posterior pharyngeal wall and anteriorly. So again, a bit of a rare complication, but it's something we should always keep in mind. So in summary, what we did over the last 15 minutes or so is that we talked about our friend, the oropharynx. And so what I wanted to leave you with was that, remember, the oropharynx is this rectangular area in the posterior portion of your mouth. We talked about those four areas involving the tongue base, the soft palate, the tonsil, and the posterior pharyngeal wall. And my hope is that over the last 15 minutes, you have a better understanding of the anatomy of this area, and you have a better understanding of a differential diagnosis that's going to allow you to take better care of your patients. So thank you very much for your attention, and I'm happy to answer any questions.
Thank you so much for that awesome lecture, Dr. Mukherji. We will open the floor to questions. So if you've got one, go ahead and toss it into that Q&A feature. And there is one in there already, Dr. Mukherji, if you want to pop that open,
Okay.
or I can read it to you, you tell me.
Let's see, where should we start here? Should we start? You go ahead and read the first one so I know where you're starting from, Ashley.
For sure. Is there any role for spectroscopy, in evaluating head and neck masses?
Yeah, that's a good question. I mean, I spent probably 20 years of my career doing MR spectroscopy of the head and neck. The challenge with head and neck, so I mean, there is a role if you have a patient that can hold still and then you can place your voxel in the exact location. And the biggest challenge with head and neck, specifically neck spectroscopy, is the motion. And then also the interfaces, because if you are performing MRS of the head and neck, the spectroscopy does not like various interfaces, and it doesn't like bone, and it doesn't like air. So the challenge that we ran into spectroscopy, especially when we were trying to do two-dimensional CSI, is that when we took our overall voxel, if we included in that voxel air, bone, and soft tissue, it would end up giving us a really poor shim. So as a result, it wasn't very helpful. But if you do have a patient that can hold still, and maybe if you did something in the neck, the lower neck, as opposed to the oral cavity, the oropharynx, then it's possible to get a pretty good shim that can help you evaluate some of these indeterminate tumors.
How often do you see a SCC from the oropharynx metastasize into the pituitary gland?
Extremely rare. Very, very rare. In fact, there was a case recently that we didn't necessarily think it was metastases, but sometimes if a patient is put on immunotherapy, you can get pituitary hyperplasia. But in general, it's pretty rare to see oropharynx squamous cell carcinoma metastasize to the pituitary.
Is MRI neck superior to PET CT for staging of oropharyngeal CA? Excuse me.
Yeah. No, that's a great question. So one thing that I didn't get into, but I can talk about it right now, is that let me just get some water here. Mm. Um, when we are evaluating the head and neck, and I'll answer this in two parts, is an MR probably is more sensitive to detecting abnormalities than CT. So when I am in Europe, the majority of the images that I'll see in the oropharynx are MRs. In the US, we tend to do more CTs than MRs for head and neck and in head and neck tumors. And part of the reason is the following. Part of it is it's pretty much, I don't want to say standard of care, but if you have an oropharynx cancer in the US, most patients end up getting a CT and or a PET CT because we want to look for distant metastases. And part of our healthcare system in the United States is that people have a fairly high burden when it comes to financial issues. So they may have what we refer to as a copay. So they're going to have to pay part of that. So from my standpoint, when we're trying to decide whether to get a CT or MR, in general, if something is below the soft palate, then I like to recommend a CT and a PET CT because the patients are already going to get it anyway. And then in general, you can make your decision-making process off of that. But on the other hand, if you do an MR, you can probably see the lesion better. But the MRs are actually fraught with more motion artifact. And also, if in the US, if you get the MR in addition to the CT, it is going to be a bit more of an out-of-pocket pay. So it's not as straightforward as you would like to be. But if someone asked me, do you see lesions better on CT or MR? Then I would say MR. Number two, regarding PET CTs, the reason we get the PET CTs is not to evaluate the primary site. Rather, it's to look for distant metastases. So, for instance, if the surgeons are going to potentially resect a tonsillar carcinoma, and it may be a T2 lesion, they just want to make sure that there's no distant metastases. So that's the reason for getting the PET CT. It's not necessarily to evaluate the primary site, it's to evaluate distant metastases. And the only thing I will add too is that part of the reason we get PET CTs, at least in the US, is that many centers in the United States for radiation oncologists, they end up measuring or contouring the tumor when they treat before radiation therapy with PET in addition to the CT as well too. So right now, I think it's relative standard of care that many centers will contour based on the anatomic abnormality and the biologic abnormality too. So that's a long question, a long answer, but it was I saw a couple of questions to that, so I want to give a thoughtful answer.
Awesome. Do you have the Q&A box open now?
I do. I'm trying to figure out which one. Okay, yeah, I got it now. Okay. I got it now. Yeah. You want me to?
Awesome. Yeah, because I'm going to keep butchering those words otherwise.
No, I'm going to turn you into a head and neck radiologist. I think you've heard me talk so many times now, Ashley. I think it's good. Yeah, someone asked for CT or MR for oropharyngeal malignancies from Omar. Omer. So as I mentioned before, I think MR is probably better to detect them, but just realize a higher percentage of MRs are going to be affected by motion artifact, whereas with CTs with multi-detector imaging, for me, it's going to be a more reliable study. Are there more questions, Ashley? I just see the last one I have is from Shamul. Are there more questions that popped up, or am I not seeing them?
Yeah, it's the Q&A
Oh, Q&A? Oh,
feature.
sorry
Yeah,
about
do you see?
I
No
was doing
worry. Yeah,
I was
there's
doing
a
web chat.
couple in there.
Hold on for a second.
I
Oh,
can't.
there's a Q&A. I was doing
Yeah.
web chat. Okay, sorry about that. Okay. Oh, here we go. Yeah, I got as much time as you're going to want to take. Like I said, I blocked off some extra time. So for a patient with obstructive sleep apnea, how effective is MR in assessing posterior pharyngeal wall and soft palate thickness? So that's a really good question. I have to admit, I don't have a lot of experience with MR. I know about 15 years ago, there were several studies that were looking at dynamic imaging using MR for soft palate thickness. In general, what I end up seeing is a lot of cone beam CTs in patients with obstructive sleep apnea. So that's as pretty much as I know regarding this. So I think it certainly can be helpful, but I don't think there are that many. I think if you had to ask someone what study they're using, I think they would probably end up doing cone beam CT. Um, the next one is tests for HPV in two types mentioned. Do they need to be done both? And what's my advice? So this is a great question. Um, they're all great questions because they make me think. And I just want to let you know that sometimes when I answer these, they're really my opinion. I'm gotten old enough to know that sometimes when it comes to medicine, not everything is cut and dry, their opinions. But I can tell you that I've asked this question numerous times to our pathologists, and this is what they tell me. The most accurate way to determine HPV positive tumor is to test for PCR. So polymerase chain reaction is the most accurate way to determine HPV positivity. The immunohistochemical staining for the protein P16 has an accuracy of about 85 to 90%. So you're going to get about a 10% false negative rate. Now, some places will do immunohistochemical staining because it's just quicker and it's very, very easy to do. And some places don't have the setup to do the PCR testing. So to specifically answer your question, PCR is the most accurate, but IHE, if you will, is the most convenient, and it gets you through most cases. Um, the next one is how early do you scan your patients after primary resection of oropharynx cancers or other tumors? So that's a great question too. I like to do 3 months, and we wrote, a paper years ago following radiation chemotherapy. We always like to wait 3 months, and the reason is because I can tell you I've been confused and made incorrect diagnosis because of performing CTs and MRs too quickly after the completion of surgery. So when you do resections, like big resections of the oral cavity or advanced oropharynx cancers, you can have a lot of inflammation involved in the soft tissues. So I like to wait 3 months, and that's just my opinion. Others may do less, may do more. But again, I just saw a recent case that my colleagues showed me literally 2 weeks ago where a patient was being treated with radiation and chemotherapy in the middle of treatment or 1 month. I think it was like 1 month. Oh no, it was actually in the middle of treatment. There was this huge response, diffuse enhancement, and tumor looked like it was growing. And then they did the imaging 3 months later, and the tumor went away. So just realize that if you image too quickly, you end up having the toxicity effects of treatment. Now that's kind of called pseudoprogression. But in the old days, we didn't call it pseudoprogression. We called it acute toxicity of treatment. In general, 3 months gives times to everything to settle down. Let's see, what's the next one there? Hold on for a second, Ashley. So I did the how early do you scan? Yes, does the pterygomandibular raphe have any function? Yeah, so the pterygomandibular raphe, it sort of connects everything. It's not a functional, it's not moving like a muscle does. So it does, its function is primarily, as you mentioned, connect. So it does form a connection. So the pterygomandibular raphe, and I mentioned this in the oral cavity talk, is that, let's see, can you still see my screen or did I lose you, Ashley?
We can see it.
You, okay. So the pterygomandibular raphe is located here, and this is where the buccinator muscle interdigitates with the superior constrictor muscle. So it brings these muscles together. And the inferior portion of the pterygomandibular raphe attaches to the posterior aspect of the mandible at the myeloid line. And then the superior aspect of the raphe extends to the hook of the hamulus. So it has this area that connects these two anterior and posterior, but the raphe has a cephalad and caudate extension. So it's sort of where everything comes together. Let's see, where's the Q&A thing here? Let's see, it's hidden on my Zoom. There we go. Okay, so the next one, how does MR compare to other imaging modalities like CT or endoscopy? Well, to answer this question, it's clear that endoscopy is the best way because they can see the tumor. You know, the role of imaging is sort of to confirm what our referring physicians see at endoscopy, but the main role is really to look for that deep extension. So as I mentioned before, MR is superior to CT to look for small lesions. So I think in the oral cavity talk, I gave several examples where you could not see the tumor on CT, but you could see it on MR. So I think MR is superior to CT for detecting subtle lesions and probably also deep spread. But just realize if you're going to do an MR, you have to make sure your techs are experienced and they counsel the patients to hold still. Because, you know, when your average acquisition is 3 to 4 minutes, if that patient just moves a little bit during that 3-minute time, your whole sequence is going to be disrupted. So that's why we tend to use a little bit more CT. What are the primary MR indicators for early detection of oropharyngeal wall carcinoma? So that's a good question. I think the early MR indicators would probably be in a patient that's symptomatic. If you see an asymmetrical mass, so for instance, we'll see a lot of patients that end up having dysphagia. And if we're doing an MR and we see either a abnormal focal mass that's midline or that's paramidline, then that would probably be the earliest indicators of tumor. So if I see something like that in a patient with dysphagia, then I'll go ahead and ask the patient, I'll go and recommend in my report that these findings be correlated with direct visualization and palpation or endoscopy. So that's how I manage things because you can see a lot of strangeness at times in the posterior pharyngeal wall. So that's what I end up saying. What is the most common misdiagnosis of the oropharynx on a scan that was done for something else? Right. So I don't know if it's a misdiagnosis or not, but I probably would say, again, I'm going to say in my experience, because good judgment comes from experience and experience comes from bad judgment. I think the two most common things would be number one, the tonsils. Oftentimes, the tonsils can be kind of tricky because the lymphoid tissue in the tonsils tend to atrophy over time. They just tend to shrink. So I think sometimes what ends up happening is that in 35 or 40-year-old patients, some patients can still have plumpy tonsil. And especially I've noticed, and it's never been reported, but if I see something that's a little bit more heavy set, patients that are heavy set tend to have bigger tonsils in general. So sometimes I'll see people will misdiagnose tonsillar carcinomas, or if there's an asymmetry, again, they'll call it tonsillar carcinomas. The next thing is that area that I see here involving the tongue base and the lingual tonsils. You can misconstrue the lingual tonsils for tumors. But again, as I tried to emphasize in the talk, that if you see something like that, especially in the oropharynx, just say in your report that I see an asymmetry, but this can be correlated with direct visualization and palpation. So, I've never really had an issue recommending that, but that's what I would suggest. The one other thing too is that if you actually look at this case, this is a good example. Once we start heading down into this glossotonsillar sulcus here between the tongue and the tonsil, again, we can see asymmetry. So if I see something like this, again, just correlate with visualization and palpation. So what is the defined cranial and caudal borders of so the cranial border is going to be the soft palate, and the caudal border, and I thought I mentioned that, but I'll just go ahead and mention that again. The caudal border is going to be this area right here, which is down by the vallecula. So the specific area, and I didn't specifically mention it, but there is a fold of tissue that runs from the lateral wall of the pharynx to the epiglottis, and that's referred to as the pharyngoepiglottic fold. So it runs from the pharynx to the epiglottis, and that's the pharyngoepiglottic fold. So that's the technical area that's hard to see on imaging. So in general, a good approximator is going to be the base of the vallecula. So right here from the vallecula. So that's why I tend to use the inferior as the vallecula and the superior as the soft palate. Let's see. How do I approach Eagle syndrome? So that's a good question. So Eagle syndrome is a calcification of the stylohyoid ligament. So the stylohyoid ligament runs from the styloid process and attaches to the top of the hyoid bone. And I got to tell you, it's kind of controversial. I had one case where I saw the calcification of the stylohyoid ligament, and I got to tell you, the majority of the times it's incidental. So I will be just doing a regular neck CT for like a parotid mass, and then I'll end up seeing calcification of the stylohyoid ligament, and I'll just mention it. But I remember there was one case where I didn't mention it, and then the surgeon sent the case back to me and said, can you please mention the Eagle syndrome? So what I end up doing for Eagle syndrome, and what Eagle syndrome is, it's calcification of the stylohyoid muscle, and the patients will either present with dysphagia or they can present with a clicking sound. So when they swallow, you can have a click, and that click is felt to be due to the hyoid bone moving, and somehow because the ligament's calcified, you can get a click sound. So what I end up doing is I don't say the patient has Eagle syndrome. I will just comment on the calcification of the stylohyoid ligament and just leave it there. And then it's really up to the physician is whether it's a syndrome. About 30 years ago, I learned the difference between a disease and a syndrome. So a disease is something that we can see or diagnose. A syndrome, what I was told, is a combination of different clinical findings. And when they all come together, it's a syndrome. Now, some of those findings may be radiologic, but on the other hand, a true syndrome is our clinical findings. So when I see syndrome like this, I know it's more than just calcification of the stylohyoid ligament, but they have to have the associated clinical findings to be considered the syndrome. The next question is, what kind of MR was done, like T1, T2, or proton density? So, I'll give you my approach on MR is that there are so many sequences to choose from MR. To me, the best type of MR is the shortest one. And what I mean by that is when I think of doing MR CT, I like to think of 100 patients. And from my standpoint, those 100 patients are going to have to pay for their study. And so when I'm trying to figure out the best study to use is what study can I get that's going to be the most diagnostic? And so what I like to do is try to keep it as short as reasonably possible. So we have dedicated MR protocols for the nasopharynx, the oral cavity, the oropharynx, and the neck. So I like to do sagittal T1s without. Then I like to do axial T2s, then axial T1s pre and post, and then post with fat suppression. And then if there's a tumor that's involved in the oral cavity, the oropharynx, I like to do a perfusion sequence, but it's not the standard T1 perfusion. I like to use a dynamic gradient echo sequence because I find that the most reliable. I think if you do the standard perfusion, the quantitative techniques, you can get beautiful images and it can be helpful. But there's so much variability in perfusion, even when it comes to brain tumor perfusion. Now to map it out into the head and neck, it even becomes even more confusing. So I like to use this T1 dynamic gradient echo sequence. And for me, it's been a great way to identify tumors and also to help differentiate recurrent tumor from post-treatment changes. Um, what imaging modality is most useful as a follow-up undergoing chemo and radiation for oropharyngeal tumors? I probably would say PET-CT for that one. So I think that's sort of standard. But on the other hand, if you do PET-CT, is to please make sure that the person reading the PET-CT has some understanding of head and neck anatomy and head and neck cancer. And also, when they do the PET-CT, is to make sure that the patients don't talk and they don't move. Because I can't tell you how many times I've seen patients that have had PET-CTs following treatment with chemo and radiation therapy, and there's diffuse uptake in the tongue. And then it's read out as diffuse recurrence involved in the tongue, and then it gets sent to us to look at in our tumor board. And when we go in and examine the patient, it's completely soft. And I have to tell the surgeons that, this is probably due to artifact because the patient was probably talking. So I think PET-CT is the way to go, but if you do it, you have to make sure that they don't talk or smoke or anything like that after you inject the contrast. Those are just some practical issues that I've run into.
Dr. Mukherji, let's do
Yeah,
one or two more and then we'll wrap Noon Conference up for
okay.
the day. If that's cool with you.
Okay, yeah, that's good for me. Let's see, two more then, real quick. Let's see.
Yeah, pick your favorite.
All right, let's see. Um, so let's see, what's the best for lymph node, MRCT? I think either one is fine. I tend to use more CT than an MR, just because again we do it more often, but I think MR is just as good. For me, I like to do CT and a good quality CT because the vessel's enhanced and it's very easy for me to help distinguish between lymph nodes and vessels. So I tend to use more CT than MR. Let's see. Let's see. So what's the most sensitive way and specific for prevertebral invasion? I think that it is looking at the axial T2 weighted images. So we do axial T2 weighted images with fat suppression. What I look for is the edema in the prevertebral muscles. And I can show that and then we'll just end it there. But I think if I look at the posterior pharyngeal wall, um, hopefully you can see this, Ashley. If I look at this one, this white arrow is pointing at the normal muscle here. And then on the fat suppressed T2 weighted images, we can see this edema involving the muscle. So this is indicative of prevertebral muscle invasion or prevertebral fascia invasion. So just to be clear, there's this fascial layer right here. And then below the fascial layer is the muscle. So we sort of combine prevertebral fascial invasion versus muscle invasion. So I think it's the axial T2 images with fat suppression. All right, Ashley, that
Awesome.
was a two.
That was the two. And actually, it organically stopped. So I think
Okay.
folks have asked all their questions. And thank you so much, Dr. Mukherji, for this lecture and for hanging out for a little while to answer all these questions.
Oh, it's my pleasure. Always a pleasure to do it, and hope to do it again sometime.
Awesome. And thank you to everyone else for participating in our Noon conference and asking such great questions. You can access the recording of today's conference and all our previous Noon conferences by creating a free account. We'll also email out a link to the replay later today. Be sure to join us next week on Thursday, November 21st at 12 p.m. Eastern, where Dr. Deborah Baumgarten will deliver a lecture entitled A Case-Based Review of Adrenal Lesions. You can register for that at mrinline.com and follow us on social media for updates on future Noon conferences. Thanks again for learning with us and have a great day.